greater number of middle-class people and professional people. These diseases are going to take over here, I believe. So let's start with a case. This is a real case. So it's a 67-year-old man. He's had 3 months of progressive dysphagia for solids. He's lost some weight. He's got a background classical for the Scottish man. He's overweight. He has type 2 diabetes. He has hypertension. There's nothing to find when you examine him. And he has an endoscopy. And I don't have a pointer, but here at endoscopy you can see he has a bulky cancer. He has a bulky cancer in his lower esophagus. And this is on a background of a condition called Barrett's esophagus, where the squamous epithelium has become replaced. And when we stage him with a CT scan, I'm sorry, I forgot, does anybody have a pointer at all? No? Don't mind, I'll use my finger. On the left, he has a bulky tumor. We call it stage T4 because it's adherent to his aorta. He has lymph nodes on the bottom right, which when we sample are positive, so he has advanced disease. And unfortunately, that advanced disease is not curable. And so he is palliated with chemotherapy, and he has an esophageal stent to relieve his dysphagia. But his prognosis is probably less than 12 months. And this is the problem with adenocarcinoma of the lower esophagus, that it is locally advanced or metastatic in about 70% of people when they first start to develop dysphagia for solids. By the time that you cannot swallow solid food, it's too late for cure for adenocarcinoma. And partly that's because the disease is advanced, and partly it's because the radical treatment, which is neoadjuvant chemotherapy and radiotherapy, and then an esophagectomy, which means opening the thorax and opening the abdomen, the patient is not strong enough or fit enough to withstand such radical treatment. And so for 2 reasons, either because the disease is too advanced to cure, or because the patient is not fit enough to withstand the treatment, only about 20% of patients in the UK are appropriate for radical curative therapy. An esophagectomy carries a risk of mortality of about 2 or 3%, even in an expert centre where you do high volumes of this. People die. And nobody feels great after an esophagectomy. Nobody eats a full meal ever again. They live with it, but their quality of life is not great. Now here in India and in other parts of the world, squamous cancer is much more common than adenocarcinoma. You can see on the bottom here, the bottom graph is in dark colours where squamous cancer is common. And so it's much more common here than adenocarcinoma, the disease I see in the UK and in Europe. But I think that'll change. And adenocarcinoma has steadily been going up in incidence over the last 30 or 40 years in North America and in Europe. And although the survival on the right looks as though it's slowly getting better, that graph's a bit of a fake. That graph starts at a very low level, and although it looks as though it's increasing, the overall survival is still only about 20% at 5 years. I'm going to move through this slide. But what we want to see is early disease. We want to catch it at a very early curable stage. And by the time people present with dysphagia, the key symptom, it's already too late to try and cure. But if we can catch it early, we have about a 90 to 95% 5-year survival. So what we want to do is move from waiting till people have dysphagia and can't swallow properly to catching people at an early stage. And that's difficult. These people are not elderly. The median age is for adenocarcinoma is under 75. And as I get closer to that age, you realize that's not old. But here's a good graph, here's a good picture here. So the key determinant of survival is the T stage at diagnosis. And what we want to see is the disease on the left here, which is in the mucosa only, or maybe just into the submucosa. But as the tumor gets deeper into the muscle layer and through the wall of the esophagus to the adventitia, then that's when trouble happens. And we can treat the disease on the left endoscopically so that people don't need an operation. Now, what are the risk factors for adenocarcinoma? Well, the risk factors are having chronic reflux and injury to the esophagus over many years, and being overweight promotes reflux, and smoking doesn't help either. So the classic picture is a Scottish man. I'm very unusual for Scotland because I'm quite thin. That's because I worry about everything. But most people in Scotland are fat, and they smoke, and they have a terrible diet, and they drink too much alcohol, and they get a lot of reflux, okay? So the typical classic is a white man over 50 who is fat, who has reflux, who smokes, and they develop Barrett's esophagus. To give you an idea, this is a pyramid I use to help get my own head round things. If you take 1,000 people in the population in the West, about 10% of them will suffer from chronic reflux. So that's about 100. And of those refluxers, about 10% will develop Barrett's esophagus. And of those 10 people with Barrett's, one of them will get cancer in their lifetime. So reflux is very common, Barrett's is less common, and cancer's quite uncommon. But as you saw here, and in our country too with COVID, even if the mortality rate from COVID is 1%, a small percentage of a huge number is still a big number, yeah? And that's the problem. You're all final MB, so you remember all your histology and pathology, but on the top here, this is what the esophagus is normally lined with: stratified squamous epithelium. And in response to chronic injury from acid and pepsin and bile and nitrates in the gastric juice, the lining changes to a columnar type of epithelium with goblet cells that make mucus, and we see that down an endoscope as a change from white to pink or red, and that's what's called Barrett's esophagus after the Australian surgeon who first discovered it. And then gradually, with more injury and over many years, you get low-grade dysplasia, and low-grade dysplasia becomes high-grade dysplasia, and high-grade dysplasia transforms into cancer. Now, it's not always perfectly linear, but that's the process that happens over 20, 30, 40 years. So here on the top left, you see on the edge, that pale white color, that's squamous epithelium, and that's replaced in the center by bright red, pink, salmon-colored columnar epithelium. That's Barrett's. And the Barrett's, with special staining here for mucin, on the purple, that's all the mucus in the goblet cells. And what we want to do is find these things. So if you see here on the left, a tiny little lesion, that's an intramucosal carcinoma. And on the other one circled in yellow, we have early cancer as well. But these early cancers don't cause any symptoms. So how would we find them? Well, one clue is by understanding the biology of Barrett's and the pathology of Barrett's. And you don't need to know this for your exams, but on the surface of Barrett's, these goblet cells that contain mucus have a peptide called trefoil factor 3, or TFF3. and only then. So it's not quite unique, but it's more or less, for the purposes of today's story, think of it as unique for Barrett's esophagus. So if you can detect TFF3, you know that the patient has Barrett's. And the question is, can we find people who might have Barrett's and offer them screening, the people at high risk? This is a photograph from an Australian newspaper 20 years ago. I copied it when I was on holiday. This man on the left was the Australian or the world belly flop champion. The belly flop's when you dive into a swimming pool and don't make a clean entry. And so to be the champion is how much water you splash out of the pool. So he has to be in training, and he has to look like this to become an Olympic champion. But he is the classic person to get Barrett's. He's overweight, he has a bad diet, he probably smokes, he's a man. So here's the problem. I've told you already, Barrett's, reflux is really common. Barrett's is not common. People with Barrett's often don't complain much of reflux because the reflux is silent. It doesn't cause heartburn, it doesn't cause regurgitation, so they don't go to the doctor. And we cannot, it's too expensive to go out and do an endoscopy on everybody in the population just to look for a small number of people. So we have to do something to filter out the whole population and reduce it down to a smaller number to try and find the Barrett's. And this is what we're doing now in the UK and in some other countries as well. And it's adapted from screening for squamous cancer in China many years ago. It's just a little plastic sponge on a string in a gelatin capsule on a string. Patient swallows it in the clinic. The capsule dissolves in about 7 minutes, and then the nurse just removes the sponge, and the sponge scrapes some cells, and we send the cells off for immunohistochemistry and for cytology to look for TFF3 and to look for cytology, to look for dysplasia under the microscope, and to look for a mutation in P53, which is very common in Barrett's and is a marker of dysplasia development. Okay? And if your sponge test comes back positive, then you go for an endoscopy. If your sponge test is negative, we can reassure the patient that everything's going to be okay, that they don't have Barrett's, that they don't have dysplasia, and they don't need an endoscopy. And I won't go through this trial, but this was published, a randomized trial in The Lancet a year ago. And this is a study in GP practices in primary care, offering people with reflux a cytosponge test or not. And the ones who agreed and had a cytosponge test, we found 10 times as much Barrett's. And that shows the way forward with this kind of test. That if we can identify more people with Barrett's, we can keep an eye on them and monitor them and hopefully prevent them from getting advanced cancer. So let's imagine that we find enough Barrett's and we find early cancer. What are we going to do about it? Well, the algorithm is quite simple. If we find early cancer, by that I mean intramucosal or just high-grade dysplasia, if it comes with a little focal visible lump or nodule or ulcer, we have to cut that out. If it's entirely flat, if it's microscopic and we can't see anything down the endoscope, then there's nothing to cut out or resect, but we can destroy it with radiofrequency ablation. And sometimes you need to do both. You cut out the little abnormal looking area, and then when that heals up, you bring the patient back and you destroy the rest of the Barrett's by ablation. So this is it may not project very well, sorry about this, but right here is a very small cancer in short segment Barrett's. We use some diathermy around the edges so we can identify it, and we then cut it out down the endoscope. We pin out the pieces flat, they go to the pathologist, and our expert pathologist looks at very thin slices to see how deep the level of invasion is, to confirm that it's just in the mucosa and it hasn't gone deeper into the deeper layers. And then there is a different technique. I don't do this, but we have it in our centre. If the lesion is slightly bigger and we don't think we can get rid of it all easily, then you can inject underneath it to lift it up, called submucosal dissection, and you can try to fillet it out and remove it that way. It's a much more complicated procedure, but you can take out in one piece a complete resection. It takes a lot of skill, and it's only available in a small number of centres. There may be some pathologists or anatomists in the faculty here. I put in a slide to give you something to enjoy. And this is histology. This is what a specimen looks like that the pathologist sees. And you can't really see the black line here very well. But here, this is the muscularis mucosae. So above the line in yellow is the mucosa, and below the line is the submucosa, and this person's cancer is only in the mucosa. So the chance of it already involving their lymph nodes is 1 or 2%. So if the disease is just in the mucosa, we've probably cured them. But if it gets down into the submucosa, the chance of there already being spread to the lymph nodes is about 25%. So that person has probably not been cured by endoscopic treatment. And then we have a difficult decision to make. Do we hope they're okay and keep an eye on them, or do we now send them for surgery? So it's important that we analyse the pathology very carefully. But if all is well, or we can't see a lesion, we destroy it by radiofrequency ablation here, and we can burn away the Barrett's, and then it reheals with a new squamous lining. And so after treatment, the Barrett's is gone, and the patient has a neo-squamous epithelium, which works, and the Barrett's doesn't come back in the vast majority of patients. So in summary, we need to target high-risk people, and we need to find more Barrett's in the community, and then we need to be better at finding the cancer or early cancer within it with high-resolution endoscopes, and we think that AI, artificial intelligence, when we show high-definition endoscopy, might point us and tell us where to look. That's still a research thing. And then we need to be better at endoscopically curing people. And I think using this kind of stepwise approach will allow us to get better outcomes from this disease. And this disease may not be common in Asia just now, but it's going to get more common in the next generation, I strongly believe. So, it's getting more common. Reflux and obesity are the big things. It turns into Barrett's. Barrett's is bad. Barrett's is also good because it gives us a biomarker. It gives us something we can target.